All right, so let's talk about chapter 26. And we're getting to the point in the book, move my head a little bit, where we're starting to put things together, where we're trying to take some math and concepts earlier and now like almost apply them, figure out what they mean. So we're going to talk about healthcare delivery, finance, and reimbursement. So this may be a review for many of you, but we need to go back over it. So what is a healthcare delivery system, and who are the stakeholders? Those are important questions that we need to talk about, right? So a healthcare delivery system, trying to get my head all the way out of the way, includes basically everyone that goes into the healthcare process. And we often, when we're trying to plan this out, forget at least one pathway here. So we know that internally it's the people providing healthcare, right? But there are other people involved, professional organizations, government overseers, the things that tell us what we can do. The people who are making policy and law, government providers, insurance providers. So these are the people paying the bills. Pharmaceutical industry, because what they make will impact what we're doing. The medical device industry, same reason. Other suppliers, same reason. Consumers, right? They're part of the delivery system because they have to come use it. And caregivers, the people that are helping the consumers do what they're doing, right? As well as investors. No matter what healthcare system we have, there are always investors. Whether we think of somebody who owns a piece of stock or a part of a company in a for-profit organization, or like if a dentist owns their dental practice, that's what we're talking about, or in like a nonprofit, the people who work there, they're the investors. They're the ones investing their time, effort, money, and while the company owns itself and there's no shareholder anyway. But yeah, so there's a lot of investors, educators, because we got to teach people how to use the system and when to use the system, and professional organizations, which will kind of dictate our practice sometimes and how people will interact with us. So first we got to define all these areas and talk about what's associated with the different things and what are the duties of finance. And really finance is going to talk about money, right? And getting money and paying money. That's as simple as that. What is reimbursement? That's part of the finance area. And that is getting paid for what you did. It's not that well, yeah, it's hugely complicated, but the idea isn't that complicated, all right? So I want to skip ahead between finance and reimbursement, right? You would think that reimbursement is just getting money to finance. But then the question is, what happens if they don't? Then you can't pay your bills. So that's bad. All right. So reimbursement depends on a number of things. The first one is, about half medical bills now are being paid by Medicare and Medicaid. And so we got to deal with the government. The government has the most convoluted and screwed up processes ever in the history of billing. And what's happened is then, because they're so big, hospitals and healthcare systems just get used to this, and then everyone else models their processes off the government. So when every time the government complicates something a little bit more, all the insurance companies get complicated as well. Almost always, I'm going to say 99% of the time, dealing with a private insurance company is better and easier than dealing with the government. So, yeah. It's so much easier to appeal something or do something or refile a claim with a private agency than it is with the government. Almost always. Government doesn't have to be efficient, whereas insurance companies or people that are working to break even or make a profit have to be. So it can get really complicated. Now, I'll give you an example of this and how this has gotten so out of whack. And I think I may have said it in this class before, but when you hear about someone paid $20 for an aspirin at a hospital, well, they got billed for $20. And what happened a long time ago is Medicare started saying, okay, you know what? We can't pay 100% of this bill, and because we can't afford it, will you accept 80% of this bill? So hospitals, yeah, we can do that because we'll make a little bit of money somewhere else. So what did they do? They took that $1 aspirin and they started charging everyone else, $2, and then they would get back 80 cents from Medicare. Well, then Medicare is like, hey, look, I can only pay 60% of your bill. So they're like, okay, yeah, we can figure that out. So then they started paying Medicare $2 or charging Medicare $2, and then getting back, what is that, $1.20 from Medicare. And Medicare's like, yeah, we can't afford that bill. So it got to the point where they just kept raising the prices, and Medicare kept just saying we're going to pay a lower percentage, and then everyone else just pays these weird percentages of bills, because that's how Medicare started doing it, and and that's where you see a lot of times these crazy prices for things. No one actually pays them. No one ever does, unless you're a cash-only patient. But then if you're paying cash, you can just go and be like, what would you really take in cash? And you'll see someone that has a $100,000 bill go, yeah, we'll take $11,000 if you're going to pay us in cash, and we're good. Because the prices have gotten so inflated because of the processes that government has used to make the bills. That's where it's gotten out of hand, and we need to do it. Like, stop. Let's rewrite all these rules, because you've built a bad rule upon a bad rule upon a bad rule, and it's just gotten out of hand. All right. So you see the third party expense, right? Right now, Medicare, Medicaid is paying about 36% of bills, and you'll see this different. This was back in 2015. These pieces of pie have expanded, and what they've done is this. All other payers includes people who didn't pay their bills. So if you just look at people who actually pay their bills, whether it be through insurance, cash pay, or Medicare, Medicaid, these have taken up about 50% now. All right. So really, we've looking forward now at how to make reimbursement and finances work. That's what the rest of the chapter talks about. There are different ways to do this, and we'll go into those in the next couple of chapters. Okay. So one thing that's been a trend is value-based healthcare and its impact on finances. Now, I'll give you the short version of this, and I'm going to let you read the rest of it along the way. The Affordable Care Act and a couple other pieces of legislation basically said, hey, look, we got to get value for money, and the more value we get for our money, the more we're willing to pay you, and the better you'll be off. So if you do a good job, we'll pay you more. Sounds like a great idea. The problem was it backfired in some ways. And the easiest one to look at is part of the value-based progress. How was value defined? And value was defined in a number of ways. And let me scoot ahead in the chapter and find that. And the important ones are readmission reduction. So if you have less readmissions, we're going to pay you more, because you obviously are doing a better job if you have less readmissions, right? Yeah, it makes sense. If you have less hospital-acquired conditions, people are getting less nosocomial infections, are getting less infections in the hospital, things that are preventable, CAUTIs and things like that, then we're going to pay you more. That sounds great. You do a better job, we're going to pay you more. Here's where some of the other things went a little awry. One of the things that they base value on is patient reviews, patient satisfaction scores. And in healthcare, we've learned to love and hate these things because of how they've been applied. And I truly believe, can't prove this, someone probably could, that the opioid epidemic was caused by the Affordable Care Act in a number of ways. Not completely, but in a number of ways. Because what happened, if you look at opioid prescriptions, since the Affordable Care Act was passed, they went way, way up. Because, when people are hurting and they go to the doctor and the doctor refuses to write them a narcotic, and then they trash them on their patient satisfaction score, the doctor got paid less. So the physicians started just writing more and more narcotics to make the patients happy so they could get paid. And then prescriptions went up. Did people's pain over the last 5 years go up? No. People's ability to tolerate pain or their willingness to tolerate pain probably went down because they could get narcotics. And when you're writing more narcotics prescriptions, you're going to get more addictions. So has the government done anything about it? Nope. No. They just really cracked down on how many narcotic prescriptions you write and where and when. Has that reduced the opioid epidemic? Not really. If you look at the amount of narcotics being prescribed, it really hasn't gone down. So this is one of those things where it's good in some ways, but not good in others. And that's Greg's personal take on this. But it's something I saw in practice. So the rest of this chapter, the next few chapters, are about MACRA, MIPs, and APMs. I'm going to put up a question in the discussion about this. One thing about MACRA that I always get involved in, because I love informatics, I love it, but one of the things that we were charged with a while back was meaningful use. And when you take informatics with me, like this term will drive you up a wall because we never really defined what the heck meaningful use was, right? We have all this data and you have to meaningfully use it. And if you do meaningfully use it, we'll give you extra money. And if you don't, we're going to penalize you. Great. What does that mean? We don't know. Just do it. That's what happened. So meaningful use, like the term became a swear word in healthcare. It's just terrible. They updated it and saying, now it's modified and streamlined with a new name. They really change it, which has been very frustrating. All right. Reading through the rest of the acts and the different quality measure concepts, those are important. Quality improvement, quality measures are what drive basically everything what we do today. We want to put better healthcare out there, cheaper, faster, all those kind of things, and we do that through quality reporting and continuous quality improvement, which are things that we are adding starting next year to the healthcare administration program, just because it's become such an important part of the healthcare system. I can't go into them now like they're full classes, but just understand that quality improvement and quality measurements are really, really important. All right. Moving on to the last chapter. Let me switch over there. There we go. Talks about MIPs and APMs. I'm just going to put a discussion question up about this. That will be more detailed than usual. And we'll talk about that there. All right. These are pretty straightforward. The question is which one's better? And that's an interesting one to answer. And it's situational. So we'll talk about it in the discussion. All right. If you have any questions, let me know. If not, have a great day.